only thing is
Hello,
Shifa.
everybody. Greetings from Heart Care Foundation of India. I'm Dr. K.K. Agarwal. I have with me Dr. Mrs. Veena Agarwal, and I have in the middle Pramod Sanghi, interventional cardiologist in New York, and now a big corona warrior because he had seen and managed the tsunami of cases in New York. He has seen a pre-tsunami era, the tsunami era, and a post-tsunami era. And why I thought of interacting with him, he happens to be my brother-in-law also. But the purpose of doing this seminar is because Delhi and Bombay today are at the verge of a tsunami. We are in a community phase. There have been a situation when there had been multiple deaths and there was no place in mortuary. We also have places where people are not getting place for their cremation. The government of Delhi now has come out that no testing is required because we are in community phase, treat patients on clinical basis. And now instead of individual cases, we are basically getting a large number of cases in community. Means every house has 7 cases, 8 cases, 9 cases, 10 cases. So I'd like to interact with you and let's see how was your experience and what do you think was the situation and what can be done in India?
Well, as you know, here in New York, we were all taken by surprise because, first of
You're
all,
all taking?
we were taken by surprise
Okay.
because we were not even aware that there were cases here. This is February. We were not aware that it was already spreading in the community. We thought at that time it was still localized in China. We did not have testing in February. And even in March, we did not have testing. And that was a big problem. The CDC actually was a little bit slow in getting the testing out. There were some problems with their testing kit, and so they had to recall it. And so we were in a situation where the testing could only be done in the hospital and not in the community. So in that situation, people were just told to stay at home if they were sick and only go to the hospital if they had severe shortness of breath. So that was the recommendation at that time, and nobody really knew what they had, if they had COVID or if they had the flu. And that was the strategy at that time. And the hospitals became overwhelmed. And we had the same problem in terms of what to do with bodies and things like that. The same problem was happening. India is in a little better situation in that the testing can be done in the community. And the testing is important because many people are asymptomatic or they don't have symptoms at the beginning and yet they're still contagious, and then they get symptoms later on. So my understanding is testing can be done. I know in the smaller towns and in the villages it's not possible, but testing is very important, of course, with all of this. And the question is still when to go to the hospital. And
So my what I wanted to know is that let me give some background. In India, when we compare ourselves to the Asia, we are seeing 3 patterns. One pattern is the China, Taiwan, Hong Kong, Korea, that group. Then we have India, Pakistan, Sri Lanka. Then we have India. Then we have Malaysia, Indonesia, that group. And then we have Arabian countries. The mortality is high in Arabian countries. It is lowest in Chinese companies. China means China, Taiwan, Hong Kong. And then it is relatively high in between in India, Pakistan, Bangladesh, Sri Lanka, Myanmar, Malaysia group.
Right.
If you go back and compare ourselves with the European countries, the mortality is very high. In between Asia and European countries, we have North America, who is showing mortality of approximately 6%. And it is in Europe, the mortality is almost like 9%. In Asian countries, it is 3%, but in Singapore and Hong Kong, it is less than 1%. So we are getting different types of presentations. What I have studied is that COVID can present as a virus, so it has a self-limiting disease in most of them. It has some antibacterial properties, so it causes rise in procalcitonin. So some antibiotics are effective. It causes hyperimmune inflammation, right? High ESR, CRP, and ferritin. So therefore, drugs like IL-6 inhibitor or hydroxychloroquine may work. In some patients, it is causing thromboinflammation, rise in fibrinogen, and rise in D-dimer. So therefore, their role of heparin comes. In some cases, it is causing silent hypoxia. So early oxygen is the trigger. In some cases, it is causing acute cytokine crisis where we are losing most of them. And in others, it is causing HIV-like reaction with low lymphopenia and low CD4 count. So the treatment may be different. If it is presenting like HIV drugs may be effective. If it is presenting like thromboinflammation, early heparin is the answer. If it is hypoxia, early oxygen is the answer. So in these situations, do you feel that what was the pattern in North America? Because if we see European countries, it was the hyperimmune inflammation which was very, very, very high. They had, all of them had COVID toe, they had skin rash, they had multi-organ failure. So inflammation was very severe in European countries. Maybe that may be the reason it is causing very high mortality. In India, we are getting more of anoxia, less of other complications. So early oxygen, people are recovering. So India is behaving like more like in Italy, where if you ventilator mortality is very high, but simple oxygen people are getting saved. And what about in US? What was your experience in New York?
So for my patient who was at home, we were trying to get them oxygen, and because we noticed that that was a problem, was asymptomatic hypoxia, and even the patients who were in the hospital, we were avoiding intubating them. We learned this early on. At the beginning, we were intubating all of them who were hypoxic, but then we learned that many of them do just fine with oxygen. And they do just fine with saturations in the 80s without having to intubate them.
No,
But
what is your, even in 80s?
even in 80s, we were not intubating. We were just giving oxygen, high flow oxygen, also BiPAP. At the end, we were really trying to avoid intubation because the mortality rate was 80% with intubation. And there was a concern that high flow with positive pressure ventilation was causing damage. So unless we absolutely had to, we were intubating. We had a lot of, in the hospital, a lot of cytokine storm, hyperinflammation. We had renal failure, many patients on dialysis, many patients with pulmonary embolism, stroke, and MI. So that was a big problem here, was the hypercoagulability state. Patients were also presenting as pulmonary embolism, but when we do a CTA of their chest, it was normal. But they had all the features of pulmonary embolism, right heart failure and elevated pulmonary pressures, things like that. But still, the CTAs were sometimes normal. So there's something going on in the microvasculature. But initially, we were waiting for the D-dimer to be elevated before we started anticoagulation prophylactically. But now we were giving it to almost everybody in the ICU.
So if I have to find out a catch, so my study says is that the time you get silent hypoxia, give him low molecular weight heparin. Start at that particular moment.
Yes. Yeah.
Instead of waiting for the breathlessness to appear, if there is a silent hypoxia, start low molecular weight heparin, because silent hypoxia may be because of microembolism.
Yes.
Small microembolia, thrombi.
Right.
That's one. Second is, what is your experience on remdesivir?
When I was in the hospital, we were not part of the trial at NYU Hospital. We were not part of the trial for remdesivir. So by the time I left rounds, we were not giving it, and the results had just come out around the time that I had stopped rounding there. So that was something we were not giving, but they started giving it later, once it became approved.
So what are the results now with remdesivir?
So what are the reasons?
What are the results now? I mean, is it effective?
The results are showing that it reduces hospital stay, and it's better to start it earlier than later. The study was not powered enough, as you know, to show a mortality benefit, but it does reduce hospital stay by several days. So, and I think it's better to give it earlier than later. So I think any patient, if you have it available, any patient who is hospitalized, I think they should be started on remdesivir.
Again, because the study says that at the point of hypoxia,
Yes.
you start putting it down. Means a patient is having hypoxia, give him a low molecular weight heparin, start remdesivir straight away for 5 days to reduce requirement of intubation.
Correct. And that's the protocol.
What about antibiotics? What about IL-6 inhibitors?
The IL-6 inhibitors we were giving, whether or not I didn't see any personal benefit, but of course I can't speak for the whole country, but those studies are still underway. So I don't know if there's truly a benefit of giving the IL-6 inhibitors, but we were giving it.
Okay.
I didn't personally see any result from it.
Hydroxychloroquine
We were giving. Azithromycin we were giving. We were monitoring the QT interval. Now there has been some negative studies recently that have come out, where in hospitalized patients it's not necessarily helping. Also, it's not
withdrawn. Both the studies have been withdrawn by the Lancet and New England Journal of Medicine.
Correct. They have. So nobody really knows. We were giving it. I think most hospitals have stopped giving it. Whether it works at home is still a matter of debate. That is still unknown. And so I'm still giving it to patients who are at home who end up getting COVID or who are at high risk of getting COVID. I'm still giving it. And the reason is it can prevent the cytokine storm, theoretically. It won't prevent you from acquiring the virus. That has been shown. There was a New England Journal article that came out just a few days ago that showed that if you give hydrochloroquine prophylactically, it won't prevent you from actually still acquiring the virus. But that we already knew. The point is, can it prevent the cytokine storm once you have it? And
so what is the percentage of people out of 100 people? How many of them have hypercoagulable state?
I think it's still out of 100 people who get the virus. Remember, about 20% get sick enough where they have to be hospitalized. I would say maybe 1 to 2% develop some sort of hypercoagulable side effect of this. 1 or 2%, but I don't know the numbers.
Therefore, I would say the predominant thing is hypoxia.
Maybe the case, yeah. Now, remember, it's a younger population, so that may be the reason. Because that is seen in the younger population. Although we are getting the thrombotic events also in patients in their 40s and 50s, and I've seen many of those. I've seen people who recovered from COVID, and they go home, and then they come back with an MI or a PE, and that happens even up to 2 months after they recover from COVID. So there's still something that's making them hypercoagulable even after they recover, up to 1 or 2 months. So actually the protocol is to send patients home on anticoagulation who have been hospitalized, discharged. We're still sending them home on anticoagulation.
Which one? NOC or what? Which one? Which medicines you are giving post-discharge?
So we're to either
rivaroxaban or
Xarelto mainly out of ease once a day.
So it can be on a low molecular weight heparin followed by a anticoagulation at home for 3 months, 6 months, 2 years. What? You don't know.
Just for 2 months.
2 months.
Just for 2 months. Yeah.
Okay. So we feel that you feel that if a patient is on the home monitoring or if the patient is in a hospital, we start with oxygen whenever there is an oxia. If remdesivir is available, we give. If patient requires, immediately start low molecular weight heparin. Go on increasing the oxygen to keep the oxygen level between 92 to 96. If the oxygen level is more, shift to high flow nasal cannula. Give a trial of a BiPAP, and then if nothing works, then he goes for a ventilator.
Correct.
And then ventilator response is that mortality is very high. So therefore, every effort should be made not to intubate.
Right. That will depend on how much respiratory they're in. So if they're comfortable and they're still hypoxic, all effort should be made not to intubate.
What about self-proning and oxygen on proning vis-a-vis proning in ventilation?
On ventilation, all patients were being proned every day, at least 12 hours.
And what about oxygenation? If they are on oxygen, are you proning them, or self-proning without oxygen?
That we were not doing, but that makes sense. I think now that makes sense to do if they're either at home or either in the hospital but not intubated. It's probably a good idea to prone them. It's much easier.
And what is the total mortality rate?
Total mortality rate it's very difficult to tell. The mortality rate in the hospital was very high. It was about 20% of hospitalized patients. That was the mortality rate. Of intubated patients, it was up to 80%. Now at home, I think if you look at all comers who acquire COVID, that of course I'm only getting from the news. I think that ends up being about 1 to 2%.
What is the level of community transmission? Means what is the community prevalence of people having asymptomatic infection? Is it 20%? Because people say as in New York and a couple of studies done, they show that 20% people have antibodies present.
Right. They did a study looked at about 35,000 people at random in New York City, and I think 16% of them ended up testing positive with the antibody.
And without any symptoms.
Without symptoms. Well, I don't.
Why I'm asking is because we say the R naught value for COVID is 3. If R naught value is 3, then herd immunity threshold will be 3 minus 1 divided by 2. That means for herd immunity, we require 67% of the people getting affected. And in New York, at a level of when 20% of the people got infected, the first wave got over.
Correct.
So we are all presuming in Delhi and in Mumbai that maybe that when we reach 20% of the population like New York, then only we will get reduction in number of cases. At this moment, every day number of cases are rising.
Right. See, New York, because there was no testing and the lockdown was very late, there was a very high spike in cases. And but in India, the lockdown happened much earlier. So you'll still see a lot of cases, but of course the curve has been flattened, right, in India, but it's continuing to rise. Whereas in the US,
how many cases are there in New York now?
I haven't seen lately what is the total number of cases. I know deaths is something around 30,000, 35,000 deaths that I know. And the number of deaths in the US has been, I think, 110,000 now.
So before I close, I have few questions. Is India start producing remdesivir? It will be available by the end of June. 3 companies are making in India, and that is Zuventus, and we have Fortio and Cipla. Abhishek Jaswal, Nikul Panchal, Ankur Satija, Ankur, good evening. Hello, sir ji. Does it mean all hypoxic patients should be given heparin? Yes, Nandari ji. At the onset of heparin, we should give it. At the onset of hypoxia, we should give heparin with that. सर फ्रीज में कितने दिनों तक वायरस एक्टिव रहता है? फ्रीज में कब तक वायरस एक्टिव रहता है प्रमोद जी? वो कह रहे हैं कि हमारे फ्रिज के अंदर में वायरस ठंड के अंदर में जिंदा रहेगा कि नहीं रहेगा?
Can virus stay
in a fridge, in a refrigerator?
That is,
How can
I think it can.
anything can preserve because we keep all our viral media in the fridge
Right.
with that. But then uh, yes, Nikul Panchal ji, thank you very much for noting down that the spelling is wrong. I'll correct it immediately. And if how do I compare? How do I differentiate between allergy and COVID? If I have allergic cough vis-a-vis COVID, how do I differentiate?
It is sometimes difficult. Dry cough is in. You will see in COVID. It won't be a productive cough. It'll be dry cough. I think in allergy it will also be dry. But fever, most patients do have fever, either a low-grade fever. So it's the whole constellation of symptoms. But it's sometimes difficult to tell. But fever, I think, is one of the distinguishing points. Whereas an allergy, you shouldn't really have fever.
Pratinder Singh, how long immunity stay after COVID? We don't know. Still, we don't know. What about healthcare workers coming in contact with positive patient, which was later diagnosed? Without PPE, it's your fault. You have to wear PPE today. We know there is a community transmission. You have to make sure every patient is positive unless tested negative. So wear PPE. But if you haven't if you haven't worn a PPE, and if you have a contact time of more than 30 minutes, you are a very high risk. So whenever you assess yourself, ask yourself a couple of questions. A, am I at risk? B, is my environment at risk? C, is my profession at risk? And four, am I prepared if I get an infection? So therefore, if you have a high risk profession and you also are at a high risk, you need to compromise with your profession with that. So anything else? What do you think? Take healthcare worker involvement in New York. How many people got involved? How many people, the healthcare workers got infected, percentage wise?
I think about 30%.
30%.
I think about 30%. 30% of, I should say, are you asking what percentage of healthcare workers tested
Got
positive, or
infected.
of the community are healthcare workers?
No. How many healthcare workers got COVID-19?
That I don't know the statistic. I know it's quite a bit. I know it's
How
quite a.
many doctors died in New York?
I personally know 3, and I knew a few who were also sick and were on the ventilator. But I'm not aware. I don't know the statistics for that.
Okay,
But
so I'm going to close with one point. If I have to find out, like we say, in jaundice, fever disappears, jaundice disappears. In dengue, fever disappears, and then sudden weakness is the trigger for endothelial dysfunction and a capillary leakage. Similarly, in COVID, what is that trigger? If we identify early enough, we can save the person. Is it hypoxia? Is it rise in ESR, CRP, or ferritin? What is that thing which, because blood test cannot be done every day. Labs are reluctant to do blood tests of a COVID patient. And therefore, is it hypoxia? That if we can detect hypoxia early. So I tell my patient that take your oxygen levels on walking or on talking. And if you walk or you're talking, your oxygen level drops. Start heparin and start oxygen and then look for a hospital.
hypoxia is the initial insult, which is very important because otherwise you can easily pass away at home. I've had patients who were feeling fine and they passed away at home. They became short of breath, and within just a matter of hours, they died at home.
So
So
I'm only going to say is that if hypoxia is detected early,
yes,
and if oxygen is started early, can we prevent complications?
you cannot prevent the cytokine storm, to my knowledge,
Okay.
but you can prevent sudden death at home. So that's very, very important, that identifying the hypoxia, starting oxygen very early. That will save lives. But I don't believe that it will prevent the cytokine storm if you give oxygen. I think that is inherent in the nature of the virus, and that's something that we still do not know why certain patients are getting that and certain patients are not. that's something that I think I don't know if we'll ever know, or we'll figure that out later. But regardless of whether they're hypoxic or not, they're still at risk of cytokine storm. There are patients who are completely asymptomatic, and then they come to the hospital with a pulmonary embolism or a stroke. Had a patient who came in with a stroke, completely asymptomatic, and came in with a stroke. They tested positive. A young patient in his 40s. So I don't know if the two are correlated, but definitely oxygen has to be given right away. Very important.
Thank you. I'll ask Dr. Mrs. Agarwal to sum up and say thank you to everybody.
So that's you, Pramod, and having dealt with the situation there, and glad to know that cases are declining now. We can use all this wisdom that you have told us, because we are in a bad shape now with the cases rising, and I'm very happy that I have KK to look after all of us, because he knows what needs to be done. And so that's a big thing, and of course the inputs from you. So all the best.
Thank you. Thank you for joining us.
For
I'll
having
send
me.
it and forward it to your friends. Thank you.
Thank you.